Okay, so without any further delay, we'll start our session. So this is after yesterday, we come back to our PG presentations. So first, I'd like to extend a warm welcome to all the four of our judges who've taken time out to come and judge your sessions. So a big round of applause for the four of them. Yes, so we start with our poster podium presentations. So we have in total 12 presentations. I would request you all to again just recollect the same rules we have, just that the time is even lesser now. You have 4 minutes per presentation and it's an additional +1. Okay? So wrap up your presentation, you'll get the warning bell at the end of 4, and then at the end of 5, we just switch off the mic. Okay? Yes? So the minute you hear the bell, I would suggest you start wrapping up, because otherwise you miss out on whatever key points you have. Don't trail off. Better than that, just wrap up your slide and then just give your conclusion, right? End well. Okay, so I wish you all the best. I first call upon Dr. Shivani to come and present her poster. Maybe go a little more, zoom in a little bit, and then maybe zoom in a little bit.
I'll start.
All of you, when you're starting the presentation, go with that one slide, and then zoom it so that we know how it is.
Ma'am, I'll start.
Yeah, please
Yeah.
start the timer, please.
Good afternoon, everyone. The title for my today's topic presentation is Migrating Air Bubble Post DSEC with Surprise Subsequent Graft Attachment. So, DSEC is a surgical treatment for corneal edema caused by reduced endothelial cell function. Some authors have reported that graft detachment is the most common complication after DSEC, occurring in approximately 14 to 23% of the eyes. A few case series and case reports have stated spontaneous reattachment of detached DSEC grafts. These detached grafts can be managed post-operatively by graft repositioning or injecting air into the anterior chamber, also known as rebubbling. If the air or gas migrates posteriorly, then maintaining a supine position and dilating the pupil can bring this gas forward and help with graft adhesion. So, this case report highlights the spontaneous reattachment of a DSEC graft 1 day after surgery in a case. No other interventions were performed after the surgery. So, in methodology, slit lamp evaluation, DSEC surgery, and SFIL implantation was done. So, a 70-year-old female resident of Mysore, housewife by occupation, came with complaints of left eye pain and diminution of vision since 6 months. The patient had history of both eyes cataract surgery done 10 years ago elsewhere, and history of diabetes, hypertension, dyslipidemia. She's on treatment for it since 20 years. On examination, we found that patient had corneal edema, corneal deep vascularization in 2 quadrants, central corneal scarring, irregular pupil in left eye, and ACIOL in both the eyes. So this patient was diagnosed to have pseudophakic bullous keratopathy or corneal decompensation secondary to ACIOL in the left eye. Hence, this patient was planned for DSEC with ACIOL explantation, with SFIL implantation, with intracameral SF6 gas in the left eye. So DSEC surgery was done with SFIL implantation, and intraoperatively at 4 to 5 clock hours, nasal iridectomy was noted with a broken ACIOL. Pupilloplasty was not done on the same day due to hazy cornea and positive pressure. So on the first post-operative day follow-up, graft detachment was seen on ASOCT as seen in the first image. So the patient was advised for supine position and pupil was dilated, and after 3 hours we again did ASOCT and graft attachment was seen. The same patient was examined 2 weeks back after the surgery and graft attachment was seen on ASOCT. So early intervention in a case of pseudophakic bullous keratopathy, with a previously damaged iris tissue. With DSEC, with SFIL implantation, with intracameral SF6, it can provide an effective long-term graft tamponade and give a further better quality of vision for the patient. This SF6 gas long-term tamponade along with strict supine position. So this case report emphasizes the value of managing corneal decompensation to prevent further complications and loss of vision. Thank you, everyone.
Yeah. Which step the air bubble was migrated? Is it air bubble or the gas bubble?
The gas bubble, ma'am, SF6 gas bubble.
But your heading says air bubble. Okay. Which step of the surgery was the gas went inside?
Ma'am, it was seen on first post-operative day when the
Okay.
patient came for
Not
regular follow-up.
during
No,
surgery.
no, ma'am, not intra, post-op.
Okay. Okay.
Thank you, everyone.
Don't start until later. Just open your presentation. He's controlling.
Start.
Good evening, everyone. Today I'll be speaking on a case of golden hour syndrome when development takes an uneven path. So, we had a 4-year-old female child who was brought to the hospital by her mother with complaints of decreased vision in both eyes, which was noticed since 2 years, and a mass which was present over white part of the both eyes since birth. Mother gives history of diminution of vision in both eyes of the child, left eye more than the right eye, which was noticeably more decreased in bright light and was associated with glare. There was no associated pain. Mother also mentions presence of a white opacity of left pupil since birth. Since birth, there was a pinkish white oval mass over the white part of both eyes, which was initially pinhead in size and gradually progressed to the current size of half a pea. And it was painless. And there was no history of redness, watering of eyes, discharge, headache, double vision, or colored halos. There was no significant ocular history. Coming to the antenatal history, there was a history of unknown drug intake in the first trimester. Cleft lip and cleft palate was detected in the anomaly scan done at 5th month, and the photo is shown there, for which the child was operated. Natal and postnatal history was uneventful. So as I had told, there was a cleft lip and cleft palate surgery which was done at 1 year of age. Coming to the examination, the general physical examination was normal. Coming to head to toe examination, it revealed bilateral preauricular skin tags, and there was a deviation of nose to the right side with a saddle nose deformity as seen in the photo, and there was mandibular hypoplasia. Dentition was irregular, and scars of previous cleft lip and cleft palate surgeries, as described before, was observed, and the spine was normal. Coming to ocular examination, head posture was straight and erect, ocular symmetry was symmetrical, and there was nystagmus which was present bilaterally. Coming to vision, visual acuity on right eye 660, left eye hand movements close to face, and the rest of the examination was normal. Coming to the conjunctiva, there was a mass which was present over the inferior temporal limbus and cornea, which was approximately 25 to 8 mm in size. It was solid, soft, non-tender. Superior margins were well defined, and the inferior extent was not very clear. There was no hair follicles over the mass or surrounding feeder vessels. And coming to the left eye, there was a mass which was present over the inferior temporal limbus, encroaching the cornea up to 3 mm, approximately 20 into 7 mm in size, with well-defined margins all around. It was solid and soft and non-tender, and hair follicles were seen on this side, on the left eye. Sclera cornea was clear on the right eye. Coming to the left eye, except for the 3 mm of infiltrating mass temporally, the cornea was clear. Then coming to the pupil was single, 3 mm in size, round, regular, reactive, both sides. And there was an opacity which was noted in both the eyes, left eye which was more dense than the right eye. Then systemic examination was normal. Now coming to summarize, we have a 4-year-old female child who presented with paleness diminution of vision with a yellow mass since birth. And the provisional diagnosis would be both eyes congenital cataract with limbal dermoid suggestive of golden hour syndrome. Now the basic investigations were done: keratometry, A scan, B scan, UBM, ASOCT, 3D CT face, X-ray spine to rule out other systemic abnormalities. And as I said, the final diagnosis would be bilateral limbal domoid with congenital total cataract of left eye, early cataract of right eye, and bilateral meridional amblyopia and sensory nystagmus, with features suggestive of Goldenhar syndrome. Coming to the management, first we had done the excisional biopsy in the left eye, followed by incisional biopsy on the right eye. Samples were sent for histopath analysis, followed after 30 days, IOL was calculated, and the cataract surgery of the left eye is performed. And we are planning to do the cataract surgery of the right eye. Coming to the discussion, Goldenhar syndrome is a rare congenital disease arising from the abnormal development of first and second branchial arches. Incidence is 1 is to 3,500 to 1 is to 5,600 live births. Thank you. These are my references.
Do you have any post-op pictures? Like,
Post-op pictures I could not take. We have done the left eye surgery. So
why
was not
excisional biopsy and
excisional
incisional biopsy?
of both eyes along with cataract surgery of left eye.
It's done.
It's done. Post-op pictures I can.
What does the AR reading in both eyes?
Keratometry readings are here. AR readings, findings I could not.
What do you think the causes of loss of vision in the left eye? You said only hand movements. Right
It's,
eye 660.
Total cataract. Because of total cataract, the
Total cataract. Okay. What was the uneven path in this? Your heading says that Goldenhar syndrome and development takes an uneven path.
Usually Goldenhar syndrome is actually unilateral, but in this case, it happened to be a bilateral condition. In most, around 80 to 90% of the conditions, Goldenhar syndrome is unilateral. That is the preauricular skin tags and cataract along with limbal domoid is unilateral. But in this case, it happened to be bilateral.
Generally, cataract is not an association of Goldenhar.
Goldenhar.
If in
Yeah.
case it is unilateral.
Yeah. Okay, thank
Thank
you.
Dr. Anirudh? Next step.
Visible, ma'am, or should I zoom?
You wanted to zoom in?
Better, it's not visible at all.
Zoom in and maybe just keep moving depending on what you present. Sir, zoom ಮಾಡ್ತಾ ಇದ್ದೀರಾ?
It's better if you do it right.
Yes, ma'am. Okay.
Yeah, you can start.
Good afternoon. I'm Dr. Anirudh Gupta, first year primary DNB. Today I will be presenting an interesting case. Tumor masquerades. Sounds scary, but might not be. So we had a 83-year-old female who presented with for a second opinion. She was diagnosed with sebaceous gland carcinoma at another center and advised wide excision with the full lid reconstruction. She was scared because lid reconstruction sounds like a big surgery. So on examination, the patient had a cystic nodular swelling, which was in the right eye lower lid medial 1/3, which was medial to the punctum. Rest lower lid architecture was normal. Eyelashes were intact, normal conjunctiva, no other lesions around, and no palpable lymph nodes in the region. So she was diagnosed with chronic canaliculitis and posted for 3-snip punctoplasty and canaliculotomy. These are the intraop images. During the first incision of 3-snip punctoplasty, there was pus oozing out of the lower punctum, and after the pus was drained out, antibiotic lavage was done, and the probe was passed to see the extent of the canaliculi. It was around 1.5 centimeters, was measured with the probe, which is usually around 1 millimeters. So these are the pre and post-op comparison images of the same patient. As you can see, pre-operatively, right eye, lower lid, medial 1/3, medial to the punctum, she had swelling, which was painless and cystic and progressive. Post-op, everything, anatomy was restored, and there was no pain, and syringing was patent through both the punctums. So, what clinched the diagnosis of chronic canaliculitis was there was no involvement of the conjunctiva, the lid margins were normal, the lid lashes were normal, no associated involvement of the conjunctiva. So in SGC is an aggressive tumor, which is a cauliflower-like growth, has metrosis, destruction of the eyelid margins, diffuse lid thickening and telangiectasia. But in this case, as the swelling was in lacus lacrimalis region, which is usually devoid of the eyelashes. That is why it might have been misdiagnosed as SGC. So, to conclude, SGC is an aggressive eyelid tumor, which need SGC is an aggressive eyelid tumor and a great masquerader. In this case, the age of the patient, rapid progression, and elderly women might have made that prompted to the diagnosis of SGC in this case, but a thorough clinical examination and details to clinical features gave us the diagnosis of chronic canaliculitis. Clinicians tend to overdiagnose SGC because it's an aggressive tumor, so they don't want to miss it. So a good clinical suspicion can avoid unnecessary debilitating surgery and mental trauma to the patient. Thank you.
What was the history from how many days or months?
2 months, ma'am. 2 months swelling in the right lower lid.
Okay, what
without
was
pain.
the surgery done for that?
3-snip punctoplasty with canaliculotomy at our center. Earlier, she was advised to go under wide excision.
Was the pus sent for any?
Yes, ma'am. Pus was sent for culture and sensitivity.
What was the organism?
I don't remember the organism, but she was sensitive and antibiotics was.
It is a bacterial infection,
Yes,
not
ma'am,
a fungal.
Yes, ma'am. Bacterial infection.
No other systemic features, because so much of pus anywhere in the body will have systemic signs of inflammation.
No, ma'am. No other signs of inflammation.
It was only swelling is her presentation.
Swelling progressive without pain.
Okay, thank you.
Thank you, ma'am.
Not able to correlate between the findings and the symptoms that you're
That's why
telling.
it's a masquerade. That's why the diagnosis of STC was made, which was actually a chronic canaliculitis. Yeah. So it was chronic canaliculitis on examination, ma'am.
What is the most common organism for canaliculitis generally? Any idea?
Ma'am, it could be actinomyces. Actinomyces?
Chronic canaliculitis, you mean?
Yes, ma'am. Thank you, ma'am.
Good afternoon, everyone. Today I'll be presenting cosmetic rehabilitation after severe eye injury. This presentation focuses on the clinical management and rehabilitation of a young male patient who suffered from a severe eye injury. The patient sustained a penetrating injury to his left eye at work caused by a grinding blade. This image shows the blade that caused the injury. The picture you are seeing on the right side is the blade. On examination, the patient had sustained injury to the left eye, on which on examination there was no perception of light, and there was a full thickness eyelid tear and a globe perforation. And X-ray also confirmed there was no foreign body in the left eye, which was critical for surgical management. We proceeded on with the surgical management. The patient underwent evisceration and eyelid tear repair under general anesthesia. In post-operative care, we included antibiotics and analgesics. By 6 weeks, healing was satisfactory, as seen in the follow-up image. In the post-operative care, we included antibiotics, analgesics, which all healed in the process. After 6 weeks, the patient was trained in the prosthetic eye fitting and maintenance. He adapted well and was satisfied with the outcome also. The patient had no complications and had expressed his self-esteem and quality of life has been improved, as shown by his content and relaxed appearance in the picture. This was the pre-op and post-op images. First one was at the time of injury. Second one is after 6 weeks. Third one is like after rehabilitation, prosthetic eye fitting. In conclusion, evisceration and prosthetic eye fitting resulted in the satisfactory cosmetic outcome for this patient. This case highlights the critical importance of a workplace safety gear. As seen in these images, grievous injuries are prevented due to the use of safety goggles. Here also, the blade is obstructed by the goggles. Grievous injuries were prevented due to the safety goggles. Adhering to the safety standard helps create a safer work environment for everyone. In employer responsibility, it's to provide a safety and equipment and training. Employee awareness is used to use safety gear consistently. Thank you for your attention.
What was the mode of injury?
Mechanical, ma'am, due to while the patient, it is a workplace injury in the industry. While grinding, the blade has suddenly, unexpectedly broken and it fall into the left eye.
Patient is happy.
Yes, ma'am.
We are also happy.
Thank you very much.
Good afternoon, everyone. I'm here to present a poster on a case of blurred fracture of orbit and traumatic mydriasis with hypoglobus with enophthalmos and Berlin's edema secondary to blunt trauma to eye. Orbital floor fractures may result when, due to blunt trauma, the globe usually does not rupture, but the resultant force is transmitted throughout the orbit, causing a fracture of the orbital floor. Signs and symptoms can be quite varied, ranging from asymptomatic with minimal bruising and swelling to diplopia, enophthalmos, hypoophthalmia, hyperesthesia of the cheek and upper gum on affected site. Treatment is titrated to the degree of injury. A 22-year-old male presented to the casualty with alleged history of RTA with complaints of sudden diminution of vision in left eye, painful and non-progressive in nature, associated with double vision. History of facial injury with blunt trauma to both eyes was there. No history of injury elsewhere. Smaller appearance of left eye following trauma. History of vomiting 2 episodes. No history of seizures and nasal bleed was present. On examination, head posture was erect. Ocular posture, there was hypoglobus with enophthalmos in left eye, with hypertropia in left eye and asymmetrical face. Extraocular movements were restricted in abduction and elevation in left eye. Forceduction test was negative. On anterior segment examination, there was traumatic mydriasis in left eye between 6 o'clock and 7 o'clock position. 3D CT on day of presentation. was suggestive of fracture of the medial, lateral, and inferior wall of orbit with herniation of extracorneal infraorbital fat inferiorly through the fracture and distortion of inferior rectus muscle and inferior oblique muscle. Multiple facial bone fractures were noted. CT scan brain was suggestive of teardrop sign. Medical therapy is indicated for patients who present with a significant enophthalmos 2 mm or more, a lack of marked hypoophthalmos, absence of an entrapped muscle and tissue, a fracture of less than 50% of the floor, or a lack of diplopia. Surgical management is indicated otherwise. The floor can be assessed through conjunctival approach, through cutaneous exposure, or through a transmaxillary approach. The orbital floor fractures can increase volume of the orbit with resultant hypoglobus and enophthalmos. The inferior rectus muscle or orbital tissue can become entrapped within the fracture, resulting in tethering and restriction of gaze and diplopia. Significant orbital emphysema from a communication with the maxillary sinus can occur. Orbital hemorrhage is possible with the risk of compressive optic neuropathy. These are a few complications. Thank you.
What was the amount of hypotropia or hypoglobus you mentioned?
15 to 30 degrees.
Okay. What have you done following the orbital fracture? What is the treatment from your side?
Observation, because he had complaints of diplopia with enophthalmos, but Berlin's edema had resolved, and there was a fracture was not involving more than 50%. OMFS consultation was done, so they are planning for.
What was the grading of fracture? Lefort's, what any other
3.
grading was done?
Lefort's 3.
Lefort's 3. Why did you not take for surgery? Because he had diplopia, he had entrapment, he had a teardrop sign. What was the indication basically to take such patients for surgical management?
If the fracture involves more than 50% of floor, if there's gross entrapment of muscle, then if diplopia is debilitating, and he was observed for 2 weeks, and after that he was referred to higher center for surgery, which he has not undergone till now.
Okay.
Good afternoon, everyone. Today, my poster topic is age no bar case report of 2 patients with lipemia retinalis. Introduction: lipemia retinalis is a rare manifestation of primary as well as secondary hypertriglyceridemia. Fundus changes appear typically when serum triglyceride levels exceed 2,500 mg per deciliter. It presents asymptomatically as it does not always affect the visual acuity significantly. The case report, case 1, a 5-month, 2-week-old baby presented with inadequate weight gain since 3 months. The baby basically presented with failure to thrive. On examination, vision was child fixed and following light. Fundoscopy revealed creamy discoloration of the retinal vessels. Blood sample was lipemic. Triglyceride level was 2,871 international units. Diagnosed to have a familial hypertriglyceridemia type 4. Case 2. 35-year-old young gentleman presented with non-case of dyslipidemia and type 2 diabetes mellitus, presented to OPD for routine ophthalmic examination after referral from dermatology department. On examination, vision 6-6 and 6 both eyes. Anterior segment examination revealed juvenile arcus inless. Fundus, milky white appearance of retinal blood vessels. Physical examination revealed eruptive xanthomas all over the body. And the blood examination revealed a triglyceride level of 6080 milligram per deciliter, TZ of 282 milligram per deciliter with HbA1c of 13.97%. These are the skin manifestations of lipema retinalis of that patient with erectioxanthomas all over the body. And this is a fundus picture which showed clearly there is a creamy discoloration of the retinal vessels. So it is graded into mild, moderate and severe. And this is a blood sample which is collected and it showed a lipemic serum sample. Management. Restriction of fat in the diet is less than 10 gram per day, an elevated intake of protein and carbohydrate, lipid lowering agents, control of diabetes mellitus, LDL apheresis. Fundus findings in lipema retinalis can improve when serum triglycerides are normalized. Discussion. Persistent and uncontrolled hypertriglyceridemia and hypertriglyceridemia, especially in newborn and infants, can lead to other comorbidities such as premature atherosclerosis, coronary artery disease, pancreatitis, hepatic failure, which may be fatal. Hence, early detection and demonstration of lipema is very important. Timely referral to ophthalmologists for all patients with dyslipidemia should be followed. These are my references. Thank you.
What is primary and secondary hypertriglyceridemia?
Ma'am, primary triglyceridemia is basically the deficiency of the enzyme LDL-FA. What is it? I forgot that. That is mainly that enzyme. Others are other enzyme. That's mainly depends upon the pathway. So primary is that I forgot that enzyme. The lipoxygenase enzyme is there. So if it is deficient, it is primary. All other pathways, if it is deficient, it's called secondary hyperglycemia.
In how many percentage of patients, more than like 2000 you said?
Yeah, ma'am, it is divided into mild, moderate and severe. So in the mild means if the triglyceride level is some like 1200 to 1500, we can see
What is the incidence of lipema retinalis?
It is 2.5% in general population.
With patients more than 2000?
Yeah, 2500 international units per deciliter. So if it is in between 1200 to 1500, it is rated as mild, where we can see only the creamy discoloration of the vessels. If it is more than 1500, 2500, posterior pole will also get affected. And finally, if it is more than 3000, there will be a salmon colored retina will be there. So, what all are the other systemic investigation that you would like to do? Yeah, always we should do we should rule out diabetes. So we should look for HbA1c levels, and also we should look for an liver function test. Liver function test, especially we should look for SGO to SBB ratio as well as AST.
And what age can it present? Can it present earlier than this?
Yeah, it can present earlier than this, but the lipema as its retinal findings will come only when the triglyceride levels is more than 1500, 1200. It's usually it is like that.
So what was done to your patient post?
This child was failure to thrive. So it was an occasional finding of that.
After finding, did you follow up the second patient?
Yeah, second patient, we sent the patient to medicine department, and strict lower cholesterol with high protein diet was followed, and also the patient was on carbohydrates. So strictly there may no fat, and patient was started on statins on the day one also.
What was the reduction of triglycerides, and any changes did you notice in the retina with the reduction of triglycerides?
Patient didn't come for follow-up, ma'am. Actually, in the literature is saying that whenever the triglyceride level is coming decreased,
it is a reversible.
It is a reversible, ma'am. Whenever the triglyceride level is coming down, definitely the retina, lipema retinalis will also come down. That means the creamy discoloration will disappear. So it's basically a reversible thing only.
Okay, thank you.
Good afternoon to one.
You can start.
Good afternoon to one and all present here. I'm Dr. Dimple, and I'm here to present a case report on visual loss as first clinical manifestation of X-linked adenoleukodystrophy. So X-linked adrenoleukodystrophy, it occurs as a result of deficiency of the paroxysmal beta oxidation enzyme due to a range of function mutation in the ABCD1 gene on chromosome XQ28. So it causes a progressive demyelination of the nervous system and manifests as dementia, behavioral changes, gait disturbances, and visual loss. Visual loss is mainly due to the central nervous system demyelination involving the visual tracts, but primary ganglion cell denation may also be operative. So coming to the history, so a 7-year-old boy presented with decreased vision since 3 years, and also the mother noticed that there was a deviation in the left eye since 6 months, and also there is decreased hearing since 1.5 months. So the child was a firstborn from a non-consanguineous marriage, was a term delivery, and was admitted for 10 days in ICU for meconium aspiration. So on examination, the visual acuity in the right eye was counting fingers at 2 meters, and left eye it was counting fingers at 1 meter. Color vision was abnormal. Pupil was, both eyes were sluggish, and on fundus examination, there was bilateral dyspallor present. Neurological examination showed reduced tone in all the four limbs. Sorry. So the investigation which was done was a full field ERG which showed normal scotopic and photopic responses, reduced amplitudes. There was increased levels in the very long chain fatty acids in the plasma which confirmed the diagnosis. So the MRI also showed T2 hyperintensity involving the deep white matter of the bilateral parieto-temporal occipital region. Even genetic study confirmed the paroxysmal disorder in the gene panel. So the treatment, a trial of IV steroids was given for 5 days, followed by oral steroids, but there was no improvement in the visual acuity. So here is the MRI, which is showing the T2 hyperintensity involving the deep white matter of the bilateral parieto-temporal occipital region. And over here, it spares the cortical as well as the subcortical fibers. So to conclude, there's frequent clinical ophthalmological findings in childhood of ALD are optic atrophy and other disturbances of the ocular motility. So once visual loss starts, it tends to progress rapidly and lead to severe vision loss. So demyelination of the central visual tracts is generally considered responsible for the visual loss. So a follow-up of the patient with X-linked adrenoleukodystrophy by an ophthalmologist is relevant since the findings of fundoscopy usually appear with the development of the disease, and they indicate a visual impairment that tends to evolve very quickly. Thank you.
So your diagnosis is first by clinical symptoms, is it? And then
by visual loss, then we had referred them to the pediatrician, and then
how
MRI
was it confirmed?
It was confirmed by the genetic panel was done. Genetic testing was done, and the gene panel came as paroxysmal findings in it.
What was the patient presented with symptoms?
Decreased vision, and also the fundus showed bilateral dyspallor.
So was it a straightforward diagnosis, or did you have any differentials in mind?
Differentials as in for the optic atrophy or visual?
Can it be like you said a patient was in ICU for more than 1.5 months or so? Can it be hypoxic ischemic encephalopathy causing temporal failure of the disc?
Can be, yeah.
But according to you, it was
Because
confirmed
MRI
cases
was,
of genetic.
so the MRI showed the features of adrenoleukodystrophy, the pattern, which is involving the parieto-temporal and the occipital region. And it's also sparing the cortical as well as subcortical fibers. So that is indicator of adrenoleukodystrophy.
What was the
And
VP?
The blood.
VP findings?
VP findings was not done.
It was only ERG.
Yeah.
What was the investigation other than
The
MRI?
blood panel showed very...
ocular investigation. ERG or VP?
ERG was done, full field ERG was done, that was normal. Blood panel showed the accumulation of in the tissues, very long chain fatty acids.
How is the child now? Any
No, they came from West Bengal, so didn't come
no
for
follow-up
follow-up.
of the
No.
case? Because the moment we see temporal failure of the disc, first thing goes to our mind is hypoxic ischemic encephalopathy or any pregnancy-related issues caused torch infection or something like that. Thank you.
Thank you, ma'am.
You can start.
Hello, good afternoon, everyone. Today I am here to present the case 1 post-corneal ulcer complication. It is a journey, how he came to us and how it finally resulted in. So he is a 24-year male presented with right eye diminution of vision. Right eye is post-corneal ulcer treatment elsewhere 2 years ago. He was poor in follow-up there also. So he came with us like this, right eye corneal staphyloma, post-corneal ulcer treatment. It is looking like entire cornea has come out. It's looking like cornea is hanging, so hanging cornea. So methods and material, he came with complaint of right eye redness, pain and protrusion in right eye since 4 months. He mainly came with us sorting for cosmetic purpose. So it is right eye lid edema is present, conjunctival congestion was present, corneal staphyloma and corneal leukomatous opacity was present. Vascularization was present and rest details were not clear. His visual acuity in right eye at the time of presentation was PL positive and PR inaccurate. We took up for surgery and we had an intense discussion with oculoplastic consultant also, and then finally we did B scan which was within normal limits. So he was advised right eye tectonic graft under nil visual prognosis, and he agreed. He didn't wanted to go for evisceration, he wanted to give a try. And intra-op iridocorneal adhesions were noted and severe bleeding was seen. Only a portion of inferior nasal iris was remaining. So intra-op pictures are like this. So intra-op iridocorneal adhesions were there, and in between severe bleeding was present. And post. So post-op he was coming to us and he followed here. And post-op he was started on medications, and post-op IOP was there, for which one AGM was started. And in discussion and conclusion, I want to stress that there is always a need for proper follow-up should be emphasized to patients, and corneal ulcers are usually associated with tissue excavation and infiltration and necrosis. Patients can suffer significant morbidity with complications including corneal scraping or perforation and development of glaucoma, cataracts or anterior and posterior synechiae and vision loss. And untreated bacterial keratitis may result in endophthalmitis. This present post-op day 10 picture is like this, and post-op day 10 vision was counting finger 1.5 meter and superior peripheral anterior synechiae was present, and 4 months post-surgery patient underwent a synechial release. His vision improved to counting finger 3 meters. He is being maintained on topical steroids and AGM. But again we lost him to follow-up, and the only final conclusion is that this kind of patients usually come from rural setup, mostly agriculture workers and all. So we have to emphasize them, give them proper time and tell them that what is the need of regular follow-up and what is the implications if we don't follow up regularly. Thank you.
Oh, which grade of the cornea was used? Because you said tectonic. Was it a grade B or A cornea?
That grade B.
It was generally what are the complications you can expect post surgery like this?
Mainly the IOP rise can be there. That is the most concerning to us.
Then
IOP rise can be there. Then graft failures can be there.
First sign of graft failure.
And corneal haziness.
What was the history before having that? You said hanging cornea. Yeah, what was the history?
Ma'am, he came from elsewhere, some other state. There he was some agricultural worker. So that time he had some injury with some vegetative matter, and there he underwent some hospital at his home state capital. And there they treated for corneal ulcer, but there also he was told to follow up properly, but he didn't follow up. And when problem worsened, and then he came to our center for further only seeking for cosmetic purpose. So
did you see fundus post surgery, posterior segment? You said B scan was done. It was normal. So what was the fundus changes, optic disc, because of the glaucomatous changes or something like that? Did you see? Because that would have also caused a decreased vision, one of the cause.
But that was not, we not followed.
You would have missed it. Anyways, Thank you. Very good thing to get 3-meter vision from just PL. It is very satisfying.
Thank you.
You can start.
Good afternoon, everyone. I'm Meghana Kotre. My topic is Stevens-Johnson syndrome, navigating the eye involvement and treatment. The case scenario here is a 17-year-old female who presented with history of multiple fluid-filled lesions over the skin, all over the body, and the lips in 7 days. It was also associated with pricking sensation, grittiness, and watering in the left eye. The patient gives history of fever 15 days back and use of medications for the same. So there's history of use of medications 15 days back, followed by all these symptoms in 7 days. So on head-to-toe examination, multiple well-defined discrete vesicles over bilateral upper and lower limb, and the trunk was noticed. On examination, ocular examination of both eye, the visual acuity, color vision was normal in both eyes, and examination of the right eye was within normal limits. On anterior segment examination of the left eye, there was matting of eyelashes, and the conjunctival, on eversion of the upper lid of the left eye, there was conjunctival congestion with solitary, well-defined erosion over the left palpebral conjunctiva and the lateral canthus with blisters. On slit lamp examination and staining of the palpebral conjunctiva with fluorescein strip, epithelial defect of 1 into 1 mm was noted. So here treatment was advised as with the topical lubricants, that is carboxymethylcellulose 0.5% for 6 times a day, and eye drops low tip retinol 0.5% 8 times a day with weekly tapering, and eye drops moxifloxacin 0.5% 3 times a day. Here the patient was closely followed up for every 24 hours, and other systemic management includes discontinuation of the offending agent, wound care, and systemic steroids, immunomodulators like cyclosporin. So basically, Stevens-Johnson syndrome is an immune complex mediated hypersensitivity disorder involving the mucous membrane, that is conjunctiva, oral mucosa, genital mucosa. Here the conjunctiva, nasal mucosa, and the oral mucosa was involved. By definition, skin involvement limited to the less than 10% of the body area. It is also related to toxic epidermal necrolysis, and it shares this common triggers, that is drug induced, and it's precipitated by idiosyncratic reaction to medication. Although the mortality is low, acute morbidity is high, and conjunctival involvement has a potential to cause blindness. The incidence is 1 to 2 per million per year. So all forms of Stevens-Johnson syndrome are a medical emergency that can be life-threatening. So the first symptoms is always fever or flu-like symptoms, and within 1 to 3 days, red purplish rashes appear, which later become raw areas, and other parts of the body are involved, and mucous membrane involvement is there. It is mainly triggered by medications like allopurinol, anti-epileptics, pain relievers, and sulfa drugs, and also some infection like Mycoplasma pneumoniae, herpes simplex, and hepatitis A. So there are ocular manifestation in chronic phase are ectropion, trichiasis, dystrichiasis, and they can be managed by mucous membrane grafting, stem cell transplantation. So conclusion here is evaluation of the eye includes careful inspection for acute lesion and assessment for potential long-term complications. Acute management includes removal of the offending agent, supportive care with lubricants, mainly to restore the tear film, and topical corticosteroids as anti-inflammatory and to prevent scarring, and antibiotic prophylaxis to prevent secondary infections. So prognosis and eye involvement depends on the severity of the initial presentation and effectiveness of early treatment. So timely aggressive treatment is necessary.
What was the triggering factor in your case?
Patient has used an unknown drug for fever. So we don't know what drug the patient used. After that, she presented with the blisters all over the body, vesicles. Mainly sulfonamide, like sulfur drug for fever. Or NSAIDs she might have used. Paracetamol also, NSAID. Mainly depending on the how much body surface area is involved. If it's less than 10%, it is Stevens-Johnson syndrome. If it's more than 30%, it is toxic epidermal necrolysis. If it's in between, it's overlap syndrome. Whole of the oral mucosa is involved. So patient was not able to open her mouth, and nasal mucosa was involved. Only lips were involved. Trunk was involved. Bilateral arms, extremities. Mainly conjunctival congestion with watering and erosion over the conjunctiva with epithelial defect. Minimal symptoms. Usually it should be more severe. Conjunctivitis is main. Other than that, if they come in later stage, symblepharon involvement, corneal epithelial defect.
Conjunctivitis, why? What conjunctivitis? Well, do you know?
Mucus and hyperemia, you can tell.
Can it be ocular cicatricial pemphigoid? Or cicatricial pemphigoid? MMP, mucous membrane pemphigoid. Why it is Stevens-Johnson?
It could have been erythema multiforme, that is the close differential diagnosis here. But depending on the body surface area involvement and more than one mucous membrane involvement and history like drug use is there, so it is mostly Stevens-Johnson, not erythema multiforme. That is one differential here.
Thank you.
Good afternoon, everyone. Myself Rajeshwari. I'm Good afternoon, everyone. So my topic for today is steroid his to clear case. So it's like prolonged use of steroids is a significant risk factor for the development of posterior subcapsular cataract as well as glaucoma. And the characteristic cataract in this patient is mainly occupied in the polar region of the posterior cortex, just within the posterior capsule, and it extends forward into the cortex in an irregular fashion. So the three main defining characteristics of this cataract are glucocorticoid receptor activation, posterior migration of aberrant lens epithelial cells from lens equator to the posterior lens pole, and their location is a sharply defined limited central area of the posterior subcapsular region. So here is a case of 41-year-old male which presented to the OPD with a complaint of gradually progressive painless diminution of vision in both the eyes. And on examination, his visual acuity was found to be 660 in both the eyes, with pinhole improving to 618 in right eye and 612 in the left eye. And lens, like on slit lamp examination, it was found that there was posterior subcapsular cataract in both the eyes, and rest of the anterior segment was found to be normal. And on posterior segment, there was a cupping of 0.6 in the right eye and 0.7 in the left eye. And the inferior quadrant, there was inferior rim thinning was found out, and IOP in the right eye was 36 and in the left eye was 24. These are the images which showing posterior subcapsular cataract in both right and left eyes. And the patient was a known case of myasthenia gravis, and he has undergone thymectomy for the same 10 years ago, and he was started on oral steroids like 50 mg for almost 4 years, and tapered to 10 mg over the course of 10 years. And his RNFL, OCT and visual fields were found to be normal, and patient was planned for cataract surgery for both eyes. So these are the images. The fundus images are very like low quality because it was taken with the fundus camera. In right eye there was a cupping of 0.7, and in left eye there was a cupping of 0.6, and this OCT was like taken prior to surgery, so with poor signal strength, and you can see there is a RNFL thinning in the inferior quadrant. And treatment, patient underwent cataract surgery, and post-op vision was found to be satisfactory, and with right eye 6/6 parts vision and left eye 6/9, and he was prescribed with topical antibiotics with topical NSAIDs and was followed up, and patient was also put on topical anti-glaucoma medications for the same, and he was followed up for every 3 months. So main thing is like prolonged steroid intake, it also not only causes cataract but also glaucoma. So to conclude, patient with steroid dependent diseases should be examined at baseline and at regular interval for the early detection of ophthalmic manifestation of steroids, and to intervene to avoid the visual morbidities like glaucoma, which is an irreversible cause of blindness. So thank you.
Your patient had 0.6 cupping, right?
Yeah.
And NRR was healthy. So, would you like to investigate the patient further?
Yes, ma'am. Like he might had ocular hypertension was presented on like when he has come to OPD, but in that OCT it showed like RNFL thinning in the inferior quadrant.
Was his corneal thickness evaluated?
Yes, ma'am. The it was CCT was normal, within normal limit.
How was the
correction factor? With correction factor. He was a known case of myasthenia gravis, ma'am.
How was the other itis? Was it normal?
One eye it was 0.6, one eye it was 0.7, ma'am.
Then the RNFL and the fields were normal.
Fields were normal.
How are you going to monitor the person?
We are going to like perform every 3 months OCT and IOP measurements. No, ma'am. IOP measurements for every 3 months and every 6 monthly RNFL OCTs and visual fields here. Thank you.
Can start. Good afternoon, everyone. I'm Dr. Supriya. I'm here to present a case of orbital Castleman's disease, initially presumed as orbital lymphoma. Introduction, this disease is a rare lymphoproliferative disorder with a non-definite etiology that can affect lymph nodes of any body region, imitating both benign and malignant malformations. We'll explore the unique features of manifestation of orbital Castleman's disease that was initially thought to be orbital lymphoma. Materials, case report. A 40-year-old man presented with protrusion of right eye since 1 year, insidious onset, progressive nature, associated with watering. No history of any ocular complaints, and on examination, There was right eye axial proptosis with mild ptosis with tenderness present superiorly, and there was no restriction of extraocular movements. Visual acuity was 6.6, and anterior and posterior segment evaluation was within normal limits, and systemic evaluation revealed hilar lymphadenopathy on chest X-ray, and blood investigations were within normal range, and MRI orbits revealed mild hyperintense lesion in the right orbit with extraconal compartment in the anteromedial aspect of the globe, measuring 20 to 12 mm and extending between medial and inferior rectus, causing mild proptosis of 6 mm. Likely, they gave impression as right orbital lymphoma and needed histopath correlation. Treatment and clinical course, he underwent right eye orbitotomy with excision biopsy under general anesthesia, and mass was sent for histopathology for evaluation. HP showed monotonous population of small to medium-sized tumor cells, which were hyalinized, sclerotic blood vessels seen in the lymphoid follicles with increased eosinophils suggestive of Castleman's disease, which is of hyaline vascular type. And post-op, patient was prescribed oral antibiotic and he was followed up. Discussion, Castleman's is a rare lymphoproliferative disorder with non-definite etiology and has subtypes based on etiology, pathology, and clinical presentation. The most common type is unicentric, which is localized and unifocal, which usually involves one lymph node and usually hyaline vascular type of histopath variant. There is very little knowledge about the etiology of the disease, but claims to be a result of impaired immune regulation that causes abundant proliferation of B lymphocytes and also plasma cells. The most common site of involvement include mediastinum, but peripheral lymphadenopathy can also occur. Clinically, it presents a slow growing, non-malignant, painless mass that is asymptomatic. Histopath, hyaline vascular type with increased number of lymphoid follicles with broad mantle zone and hypoplastic germinal center. This disease also has a correlation with HIV and HHV-8 virus with mostly multicentric type. And treatment right now is only complete surgical resection of the tumor. Differential diagnosis is lymphoma, Hodgkin's, and angioimmunoblastic T-cell lymphoma. Conclusion, it is a rare lymph node hypoplasia known to occur in asymptomatic patients, can involve any lymph node. Further evaluation has to be done to rule out any systemic involvement. And this disease can be kept as a differential by a pathologist if any lymphoma is occurs. These are my references. Thank you.
Which is the most common location of orbital lymphoma?
Mostly medial side. I'm not sure.
Do you have MRI pictures?
Post-op, no, ma'am. He was lost to follow-up. He came intro. No.
MRI?
No, ma'am. Post-op, he was lost to follow-up actually.
There is hilar lymph nodes, there is proptosis. Do you have anything else in mind when you are investigating for the, investigating the patient?
Could be any lymph node. Hodgkin's lymphoma can be there.
Anything else?
afternoon, respected teachers and my friends. Myself, Dr. Nandini. I am presenting the case of twin crisis, navigating a rare case of bilateral acute angle closure attack. Before going to the case per se, let us understand what is the importance of this case and why it is rare. So, prevalence of primary acute angle closure glaucoma in the last 20 years, a meta-analysis and systemic review which was done in 2020 has, according to this study, the maximum patient, more than 99% of the patient with acute angle closure attack were age of more than 40 years. One more Jesem Lai et al. Study who has again present in the case series has told that primary angle closure attack glaucoma usually present with pain, and none of them, patient in his study, none of them were bilateral. And one case report was done with bilateral simultaneous primary angle closure glaucoma. According to him, he told that to have a simultaneous angle closure attack, both eye before attack should have same anatomical features under the external condition. So coming to our case, 29-year-old female presented to the OPD with pain in both the eyes since 15 days, diminution of vision in both the eyes since 15 days. Pain was sudden in onset, progressive in nature, and it was dull aching radiating to temporal side of the head with no aggravating or relieving factors. Diminution of vision in both the eye, more so in the left eye for both near and the distance, which was again sudden in onset and progressive in nature. There was no history of any ocular trauma, no history of any systemic medication. Vision with Snellen's chart, it was on 1/60 in both the eyes. Near vision was N36, color vision was normal. On torchlight and slit lamp examination showed lid edema, circumcorneal congestion, cornea was hazy with stromal edema. Anterior chamber depth was, according to Von Erich's grading, was grade 1. Gonioscopy was performed with a Sussman 4 mirror, which showed there was a closed angle in both the eyes, which was not opening even on indentation. Then IOP was performed with a Goldman stonometry. It was around 38 mm Hg in the right eye and 48 mm Hg in the left eye. Then the iris in the right eye showed there was a loss of pupillary rough and pattern from 7 o'clock to 10 o'clock position, which was suggestive of iris atrophy in the right eye. Pattern and color was maintained in the left eye. Right eye pupil was horizontally oval, mid-dilated, non-reactive to pupil. Left eye was vertically oval, around 6 mm, non-reactive to light. Then on the lens, there was multiple grayish-white patches seen on the anterior capsule of the lens, suggestive of glaucoma flecken. On fundus examination, disc appears to be smaller in size, 1.3 vertically, round with nasal blurring of margin both the eyes, suggestive of hyperemic disc. Summarizing the case, 29-year-old female, nil systemic with acute redness, pain and diminution of vision in both the eyes in 15 days. On examination, vision was 160 in both the eyes with circumcorneal congestion, edematous cornea, shallow AC, high IOP, glaucoma flecken on the anterior capsule of the lens with disc edema, more so in the left eye, and the provisional diagnosis of bilateral acute angle closure attack was made. And the patient was treated to lower the IOP emergency basis. Injection IV mannitol 3 mg per kg was given, tablet acetazolamide BD, eye drops pilocarpine 2% hourly for the 6 hours, then 4 times per day, eye drops timolol 2 times per day, and the eye drops prednisolone acetate 1% for 6 times per day was given. Target IOP of 14 and 16 was achieved in right and left eye respectively, and vision of 636 was achieved in both the eyes. Then the patient was investigation to know the cause, and the UBM B scan was performed to rule out any uveal effusion in the both eye, which it was turned out to be negative. And then the biometric parameter analysis was done, which showed there was a shorter axial length. Done, no? Okay. Axial length was shorter with the increase in the lens thickness, decrease in the AC chamber depth with IOL suggestive of hypermetropic eye. So impression of simultaneous bilateral acute attack of primary angle closure glaucoma was made. Take home message: special attention should be given to a patient with positive prescription of their spectacles to prevent the occurrence of acute angle closure glaucoma, hence the severe damage to eye and vision. Thank you.
So, was this the first attack? Like, had she had any episodes before this?
Actually, when she presented to us, she didn't give a previous history of similar attack. Ma'am, this was her first attack in both the eyes. Paracentesis was not done, ma'am. After mannitol and Dimox for 2 days, patient has improved in the IOP was continuously reducing in both the eyes, ma'am. Then 14 and 16 was achieved. PI 14, 16. Then we have asked for the patient for close follow-up, ma'am, because we were planning for any surgical intervention. Vision was not improving.
So, since the vision was not improving, how was her fundus changes? How was the disc changes?
Disc at the present, because of the attack, it was a hyperemic disc, ma'am. So we asked for the close follow-up so that once the inflammation reduces, to see for the disc changes. High pressure, she has stromal edema, ma'am, not a microcystic edema or bulimia.
Like when did she report? How many days back? Follow-up of how many months?
We have asked to come her after 15 days, ma'am, again for the close follow-up to look for.
15 days not at all.
No, ma'am.
PI is not done, no?
PI not done, ma'am. We were planning surgical. We have to intervene or what, because pressure was under control. She has improved, so we have asked for close follow-up.
Why surgical? Why not just laser PI?
If the patient doesn't improve with the vision, then so many glaucoma flicken was also there. SIMC, I mean, she had a cataract little bit. So if patient doesn't require surgical, then we would have
What is
planned.
the age of the patient?
Age is 29.
29 why?
No?
Why do you want to do cataract surgery at the age of 29?
Actually, cataract, because like what we say in the primary angle closure glaucoma, usually they tell cataract may help. Early lens extraction can help to delay the glaucoma.
We are done.
Thank you, dear PGs, and thank you, the judges. And with that, we finish our poster podium presentation. We'll tally the marks, and the BOS will get back with who's won it. Okay? So they're not revealing the results now. They will get back to you, and they will personally contact you if you won. Okay? Yeah. Thank you.
This was also good, but Steven Johnson, Castleman didn't have photos. This was fine.
Thank you so much for taking time. Thank you.